Hi, and welcome to the Pro PA podcast. I'm Angie Urbina, and I'm so excited to be hosting the dermatology section of the Pro PA podcast. Over the next series of episodes, I'll be diving into clinical medicine briefs in dermatology, covering high-yield topics straight from the PANCE blueprint to help you succeed in exams and clinical practice. I've had the pleasure of working as a professor alongside Professor Cristina Gonzalez, or Prof. G, for over 8 years. Together, we've taught courses like Intro to Clinical Medicine, Anatomy, Clinical Clerkship, and the Emergency Medicine rotation. She is one of my close friends, and I enjoy any opportunity I have to collaborate with her. As for me, I have over 14 years of experience in clinical medicine across internal medicine, family medicine, emergency medicine, and preventative health. My goal is to share practical tips and insights that blend textbook learning with real-world application. Today, we're kicking things off with acne vulgaris, one of the most common dermatologic conditions you'll encounter. Whether you are preparing for the PANCE or managing patients in the clinic, this episode is packed with pearls to help you navigate it with confidence. Let's jump right in. So let's first talk about the pathophysiology. What is acne vulgaris? Acne vulgaris is a chronic inflammatory condition of the pilosebaceous unit caused by a combination of 4 factors. Number 1, increased sebum production. Number 2, follicular hyperkeratinization leading to clogged pores. Number 3, overgrowth of Cutibacterium acnes, formerly known as Propionibacterium acnes. Number 4, inflammation resulting in papules, pustules, or nodules. So you can think of acne as a traffic jam in your hair follicles. Oil, dead skin, and bacteria pile up, leading to inflammation and visible lesions. So here's a mnemonic to help you remember the 4 causes of acne. So the mnemonic is 4, like the number 4, F-O-U-R. The F stands for follicular hyperkeratinization, the O for oil, for sebum overproduction, the U for underlying bacteria, which we said is the Cutibacterium acnes, and the R is for release of inflammatory mediators. So who does acne vulgaris affect? Acne primarily affects adolescents, most common between the ages of 12 to 24, but can also occur in adults, typically women with hormonal fluctuations due to menstrual cycles or also in polycystic ovarian syndrome. The typical areas of distribution for acne vulgaris are to the face, the neck, chest, upper back, and shoulders. Now, as far as the clinical presentation, we have non-inflammatory lesions as well as inflammatory lesions. The non-inflammatory lesions are comedones. And so we have open comedones, which are blackheads, and those are due to oxidized keratin, which causes the dark color. And then the closed comedones are whiteheads, which are clogged follicles covered by skin. And the inflammatory lesions are papules, pustules, nodules, or cysts that are also possible. Acne vulgaris has severity levels. So there is mild acne vulgaris, which are few comedones and minimal inflammation. And there's also what's called moderate to severe acne, which would be many comedones, inflamed papules or pustules, and also involvement of multiple body areas and associated scarring. Next, let's talk about the workup and the management. So the diagnosis of acne vulgaris is clinical. No labs are required in most cases. However, laboratory testing is warranted if hyperandrogenism is suspected. And this would be testing such as free testosterone, follicle-stimulating hormone, luteinizing hormone, and DHEAS. The management for acne vulgaris is a stepwise approach. Topical retinoids and topical antimicrobial agents are the mainstays for initial treatment of mild acne vulgaris. The topical antimicrobial agents being either benzoyl peroxide or topical antibiotics. For patients with just mild comedonal acne, Treatment with a topical retinoid is usually recommended. Now, if a patient were to have mild papulopustular or mixed comedonal and papulopustular acne, then we would treat with a combination of a topical retinoid and a topical antimicrobial agent. In some cases, all three topicals may be part of a patient's regimen, being a topical retinoid, benzoyl peroxide, and a topical antibiotic. When we move on to moderate acne, this is where an oral antibiotic would be added to the patient's regimen. So the regimen being what we discussed for mild acne, that would continue, plus an oral antibiotic being either doxycycline or minocycline. And then for severe acne, this is where consideration of oral isotretinoin is necessary. Oral isotretinoin is highly effective, but does require careful monitoring due to the side effects. Isotretinoin has multiple side effects, including teratogenicity, hepatotoxicity, and hyperlipidemia. So it cannot be administered in pregnancy, and liver function testing along with lipids need to be monitored. A very important pearl when managing acne vulgaris is to avoid antibiotic use without topical benzoyl peroxide, and that is referring to both topical and oral antibiotic therapy. So combining a topical or oral antibiotic with benzoyl peroxide decreases the risk for development of antibiotic resistance. So this is an important factor. Therefore, antibiotics, whether oral or topical, should be used in conjunction with topical benzoyl peroxide. Prevention for acne vulgaris. There are some skincare tips. So use of non-comedogenic products is something to educate the patients on, as well as washing their face daily with gentle cleansers. And as far as lifestyle modifications, you want to educate the patient as well to avoid picking or popping lesions. And the role of diet remains uncertain, but several studies do suggest an association between acne and increased milk consumption and high glycemic load diets. So you may want to educate the patient on that as well. So decrease milk consumption and avoid high glycemic diets. Complications to watch for. This would be scarring and psychosocial impact. So as far as the scarring, you want to monitor for hypertrophic or atrophic scars from untreated or severe acne. And you want to be monitoring for any depression or low self-esteem in these patients with visible acne. Now let's talk book med versus street med. So as far as book med, as we talked about, there is this stepwise escalation of treatment. And as far as street med, in practice, sometimes combinations like benzoyl peroxide with clindamycin are used immediately for faster results. And lastly, here's a quick clinical pearl before we test our knowledge with a couple of clinical questions. Patients often confuse acne flare-ups with treatment failure. It's important to educate the patient on the fact that acne treatment can take a while. It can take at least 2 to 3 months of being consistent and adherent with the regimen to assess treatment efficacy. So here are some clinical questions to test our knowledge. Question 1. A 16-year-old presents with several comedones and a couple of small papulopustules on her forehead and cheeks. She has tried benzoyl peroxide and a topical retinoid adapalene with no improvement. What is the next best step? A. Add topical clindamycin. B. Add oral doxycycline. C. Prescribe oral isotretinoin. Or D. No treatment and observe. I'll give you a couple of seconds. If you chose A, add topical clindamycin, you are correct. This patient is presenting with mild acne, and therefore following the stepwise approach, we can add a topical antibiotic like clindamycin to her current regimen of benzoyl peroxide and a topical retinoid. Question 2. A 20-year-old man presents with severe nodular acne affecting his face and back. He has tried topical retinoids and oral antibiotics without significant improvement. What is the next best step in management? A. Continue oral antibiotics and add benzoyl peroxide. B. Start oral isotretinoin. C. Prescribe high-dose topical retinoids, or D. Perform intralesional corticosteroid injections. If you chose B, start oral isotretinoin, you are correct. This patient is presenting with severe acne and has already used topical retinoids and oral antibiotics without improvement. Therefore, the best choice would be to start oral isotretinoin. Great job on these questions. Thank you for joining me for this episode of the Pro PA podcast. Don't forget to hit the subscribe button and turn on notifications so you never miss an episode. And be sure to look out for future episodes in our dermatology series, where we'll tackle more high-yield topics to help you prep for the PANCE or excel in clinical practice. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you in the next episode.